afternoon, everyone. I'm Zainul Abidin Assad, one of the AHA early career bloggers here with a very special AHA 2021 session. I have a very special guest with me today, Dr. Rakesh Gopinathar, who's the director of the electrophysiology lab at Kansas City Heart Rhythm Institute, and also the medical director at Research Medical Center, professor of medicine, University of Missouri, Columbia, and also the chair of the ECG and Arrhythmia Council of American Heart Association. And Dr. Gopinathar is going to discuss us about atrial fibrillation and other arrhythmia-related updates at AHA 2021. Welcome.
Thank you, Zain. Pleasure to be here.
So, Dr. Gopinathar, what do you think were the important atrial fibrillation related science presented at AHA, and if there any particular one you would want to discuss in more detail?
Thank you. I think I wanted to sort of briefly talk about a couple of studies. One was the AMAZE trial, which was a ablation trial in persistent atrial fibrillation patients that compared persistent AFib patients to pulmonary vein isolation plus left atrial appendage ligation using the Lariat suture delivery system in one arm. There were 349 patients, and the control arm was a group that only received pulmonary vein isolation. That was 196 patients, and during follow-up, the AF recurrence rate, the success rate for the freedom from AF was attained in 64.3% in the ablation plus Lariat arm compared to about 60% in the PVI only arm. And it was not statistically significant. The difference was not. And the other important point was that there have been concerns about complications associated with the procedure. However, the cumulative complication rate was for 3.8%, which was actually substantially better than expected. So I think from a safety signal from the Lariat was quite good in this trial, although it didn't meet the primary endpoint. The implication here is that we still need more work to be done to identify the suitable targets for patients with persistent AFib. The second study is called the CRAVE study. It's a small study of 100 patients which evaluated the impact of coffee consumption on atrial arrhythmias. And these patients were randomly assigned to either consume coffee or not on alternate days, and they all got a 2-week e-patch monitor, a Fitbit that tracked their physical activity and sleep patterns, and also blood sugar measurements and so on and so forth. So what the study showed that coffee consumption did not result in any increase in atrial arrhythmias, or in fact, there was a decrease in SVT in the coffee consumption group. However, in patients who were fast metabolizers of caffeine, they noted more increased number of PVCs, and those who were slow metabolizers, there was reduced sleep and increase in physical activity noted in these patients. So it's an interesting study, and I think it's a good sign and perhaps a relief for coffee drinkers across the board. To mention that these were not people, these were relatively healthy people. They didn't have any underlying cardiovascular disease, and so no other real risk factors. So it's just kind of more of a population study.
So as a coffee lover myself, I'm very excited about the study results. Plus, from a patient care perspective, this question always comes up, especially in our young patient population. So based on these study results, you think if you have a patient with no underlying structural heart disease, just like history of SVT or atrial arrhythmias, you can tell them that moderate amount of caffeine consumption is fine?
I would say so. I think that has kind of been my practice anyway, because there's never really been any data that really implicated in coffee for atrial arrhythmia. So yeah, I think everything in excess is bad, but I think moderate consumption, if you're otherwise okay, will be fine. I mean, there's always an odd patient who for whom caffeine could be a trigger for arrhythmias, but I think from a general perspective, I think it's fairly safe.
All right. So Dr. Gopinathar was the moderator of a very special session that was done on Saturday, November 13th at 3 p.m. Eastern Time, called Atrial Fibrillation in 2021, Prepare for New Directions. So could you give us a summary of that session? Like, what are the main highlights?
Yeah, thank you. Yeah, this was what we call as a main event session. So it is one of the sort of the focused sort of a state-of-the-art session tackling pertinent issues within a topic. So in this particular session, there were 4 talks, and the first one was on AF screening. And the just a synopsis of it is that why should we screen for AF? I think the reason for that is that, you know, many a times we see patients present with stroke, and that's the first time they get their AFib, and that's about 13% of like ischemic strokes present with AFib or detected after a stroke. And unfortunately, the other problem is underdiagnosis of atrial fibrillation. It's estimated that about 700,000 patients are underdiagnosed, and many of these patients have a CHATS2-VASc score that would put them in the anticoagulation bracket. There's also, you know, racial differences in the incidence and prevalence of atrial fibrillation, and then clinically what is thought to be the lower prevalence of atrial fibrillation in Blacks and Hispanics, whereas when you look at subclinical AF, that sort of that difference goes away, meaning that this could be like an ascertainment bias, or like, you know, less access to these kind of technologies or screening from. The second question is that if we screen, are we going to find more AFib? Absolutely, because the more we look, the more we're going to find. And like, you know, we know that in patients who are after cryptogenic stroke with implantable loop recorders, you know, you will get about 30% of patients eventually get AFib compared to regular, like if you do event monitoring, you get much less. And so the last and most important question is, does it matter if we screen? Are we going to make any difference basically on mainly anticoagulation? But unfortunately, the data so far has not shown any significant benefit. There were 2 studies that have been done. One is called Stroke Stop, and that you know, anticoagulated patients based on whether they found AFib with event monitoring versus, you know, usual screening, and then they found no significant difference in the composite outcome, which is a death, stroke, and all-cause mortality. And then another study called the Loop trial, which was, I think it was published, presented recently in ESC, I believe, and that also looked at ILR versus standard monitoring. And they found that the ILR detected AF in 30% compared to 12% with other monitoring. But unfortunately, you know, but despite that, the study did not show any significant difference in stroke risk. The hazard ratio was 0.8. There was increased, you know, but it didn't meet statistical significance. So essentially, we still really need to figure out who to target for screening. I think patient selection would be important, how intensively we need to do that. And, you know, we seem to understand the diversity in the screening purposes, like what are the racial, gender differences in those cases. And now with the consumer electronics, it's easy to screen, but there's a lot of noise there as well. So you just have to be very careful about how to interpret it, and because in a normal well patient, just screening could result in the opposite effect, perhaps psychologically, and all those other issues you need to consider.
Yeah, I think in the European guidelines still recommend like it's okay to consider opportunistic screening in patients more than 65. But to my knowledge, and please correct me if I'm wrong, the HRS ACC has no specific like subgroup of patients for which they recommend even opportunistic screening.
Yeah, correct. I think the new guideline should be, the current AF guidelines are a bit old, and then new one would be coming out in hopefully in the next couple of years, and then we'll see how these new trials go, ongoing trial data, how it pans out, and how that would impact the guidelines. But again, I think the challenge is to find the true at-risk population where we can make a difference in treatment. The other topic was to discuss about the relationship between atrial fibrillation and dementia. And this is a substantial issue, and AF, because of the irregularity of the rhythm, or cerebral hypoperfusion can happen. It can also cause microemboli and bleeds. All these can contribute to dementia in this population. This particular, I wanted to mention that the AF screening talk was given by Dr. Emilia Benjamin from Boston University, and the dementia talk was given by Dr. Jared Brunch from the University of Utah, both world experts in these topics. So according to Dr. Bunch, I think the dementia risk can be reduced by oral anticoagulation. And also, even in warfarin treated patients, the higher time in therapeutic range is associated with less dementia. The second point is rhythm control compared to persistently staying in atrial fibrillation had an impact on reduced dementia in this population. And the same signal was found in patients who underwent catheter ablation. And in fact, the dementia risk in catheter ablation patients who stayed in sinus rhythm was actually not that, very close to those who dementia risk in those who did not have any AFib. But, and so, and the last thing is risk factor modification also plays an important part, because, inflammation, all those aspects, especially with systemic diseases like hypertension, diabetes, obesity, sleep apnea, all those things are important to address in reducing the dementia risk. The next topic that was discussed was lifestyle and risk factor modification in atrial fibrillation. Right, what are we talking about here? We are talking about exercise, obesity management, screening for and treating sleep apnea, managing diabetes, hypertension, and other risk factors, smoking, alcohol use, and illicit drug use. So, there is a lot of data on obesity, especially done from Australian group from Presh Sanders' group, and Dr. Andrew Natale, who gave this talk, this excellent talk, went through a lot of these data, and we know that even minor amounts of weight loss can result in significant, freedom from atrial fibrillation, either as a primary prevention or after post-ablation in these cases. And it also has been shown to arrest the progression of atrial fibrillation, meaning going from paroxysmal to persistent. And there are persistent people who became paroxysmal after risk factor modification. And it significantly improves ablation success as well. And there are people with morbidly obese who have done really well and had significant freedom from AF when they had significant weight loss or underwent bariatric surgery, either pre or post ablation in that case. And I think these are very important aspects that every physician who treats atrial fibrillation should address. We need to screen people for OSA. We need to encourage weight loss, at least 10% loss from the baseline if they're obese, and aggressive blood pressure and diabetes control are important. The challenge, at least in the US population, has been, we can talk about all the important, but how good we can implement it. Unfortunately, it's somewhat sobering. There was one study Dr. Natali did. There were about 208 patients screened, only 14 patients enrolled in a freely available lifestyle modification program. And out of that, out of the 14 patients, only 37% of that completed the lifestyle modification program. And the main reason that patients reported for not being able to enroll and complete is because they felt very tired and were miserable from the atrial fibrillation, so that they did not or cannot exercise in those cases. So I think we have to think smartly about it. Digital apps can be helpful in improving compliance. Integrated risk factor lifestyle modification program that ultimately multidisciplinary, that would be the best way to go about it. But I don't think the infrastructure as we have it is not very conducive to that, but perhaps some, large centers could do it, but how can we get it down to the grassroots level is a big
question. Exactly. I think like if you look at the last ESC guidelines, they have laid like a beautiful framework on like what's the future of AFib care, the concept of integrated care of AFib, where not only electrophysiologists and cardiologists, but sleep medicine, weight loss, endocrinology, all of them are like important partners, and the concept is like centered around the patient in the form of like an AFib team. But of course, there are some ground realities and challenges based on the healthcare system we have. But I think the future of AFib care is bright, like so much exciting new science happening. And thank you so much. This was like a wonderful summary. I'm sure my fellow early careers will definitely enjoy this session. Thank you for your time.
Appreciate it. Thank you for inviting, and pleasure to be here with you and to discuss these important aspects. Thank you.